Okay, good afternoon. I'd like to call to order the Health Commission Community and Public Health Committee meeting for Tuesday, October 15th, 2024.
I will call the roll. Commissioner Gerardo
Present.
and Commissioner Christian.
Present.
Thank you. I'll read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the minutes of the September 17th, 2024 meeting.
I move that we approve the minutes.
I second.
Is there any, there's only staff in the room, so there's no public comment. All in favor?
Aye.
Great. We can move on to item 3, the TB update.
Thank you, Mark. Thank you, commissioners. Good afternoon. I'm Dr. Susanna Graves, the Director for Tuberculosis Prevention and Control in the Population Health Division. Thanks so much for this opportunity to present an update on our work. Just to provide a brief overview of what I'll be presenting today, I will start with the TB program's structure, function, and mission. And then I'll go on to epidemiologic trends in TB in San Francisco and collaborations for TB prevention and care. Next slide. The TB section is situated within the Population Health Division under Health Officer Dr. Susan Phillip. Next slide. And the TB section is part of the Disease Prevention and Control branch within Public Health Services under the direction of Deputy Health Officer Dr. Seema Jain. Next slide. The mission of the San Francisco Tuberculosis Prevention and Control Program is to prevent, control, and finally eliminate tuberculosis in San Francisco by providing compassionate, equitable, and supportive care of the highest quality to all persons affected by this disease. The TB section is located in Ward 94 on the San Francisco General Hospital campus, and it's made up of the TB clinic, the surveillance and epidemiology unit, field outreach and investigation units, and these are all underpinned by operational support from an administrative unit. Next slide. By way of background, tuberculosis is an airborne infectious disease. It's transmitted from person to person in shared indoor spaces. It's most commonly affecting the lungs, but it can affect any organ. TB is a top infectious disease killer globally and has over a 10% case mortality in San Francisco. A person can harbor TB in a latent stage for months or years without symptoms before going on to develop active disease. And TB in this latent stage is preventable with antibiotic treatment. The next portion of my presentation is going to focus on active TB disease, the deadly form of the disease that's transmissible from person to person. San Francisco has a high incidence of TB disease when compared with California, and California is a high incidence state within the US. San Francisco's TB incidence has been on the order of 3 to 4 times the US rate for the last decade. And after a sharp drop in reported TB cases in 2020 in San Francisco, as well as California and the US, there's been an increase since that time. The data you see for year to date goes through August 30th of this year. TB can affect anyone, but non-white populations are more heavily impacted in San Francisco. The case incidence is 2 to 5 times higher in Black and Latino populations, and on the order of 10 times higher among Asian Pacific Islanders in San Francisco. A large part of this disparity may be driven by exposure in higher incidence settings in countries with higher incidence of TB. Next slide. Globally, many countries have a higher incidence of TB than the United States, and the vast majority of individuals diagnosed with TB in San Francisco were born or lived in one of these countries here that are shown in the more intense coloring. And they may have acquired their TB while living or visiting these areas where TB is more common. Next slide. The highest number of TB cases in San Francisco is among people born in Asia. And when you disaggregate regions to look at where San Francisco residents with TB were born, you see that our patients come from a diverse set of countries. This comes with an even more diverse array of ethnic and cultural backgrounds. And serving this heterogeneous population has necessitated a tailored approach to provide culturally sensitive and linguistically appropriate care. Next slide. This map shows the overall TB incidence over the last 5 years by color, with blue being the highest incidence, which is shown there in Chinatown. While incidence of reported cases among San Francisco residents residing in Chinatown did decrease in 2020, it has increased and now is back to 2019 levels, and it continues to be markedly higher than in the citywide incidence and the incidence in other neighborhoods. Other higher incidence neighborhoods that are shown in teal also share population TB risk factors of having a high proportion of residents born outside the US and also a higher proportion of non-US born individuals in poverty. This is layered with other social determinants of health that are linked to potential TB exposure, like living in crowded conditions and history of incarceration. While collaborating with partner clinics, including the San Francisco Health Network clinics, as well as federally qualified health centers and health systems, we make sure that independent providers promote early TB diagnosis and prevention. Next slide. But finding and treating active TB disease will only get us so far toward eliminating TB in San Francisco. This is because the vast majority of TB disease cases, an estimated 86%, arise from latent TB infection. People with latent TB infection harbor the bacteria in their body. It's not causing any symptoms because it's been walled off by the immune system. But people with latent TB infection have a 5 to 10% lifetime risk of going on to develop active TB disease. Latent TB can be cured with just 1 or 2 antibiotics, whereas the treatment for active disease is usually 4 antibiotics or more for 6 months or more, and it's longer and complex. Next slide. There are nearly 64,000 individuals estimated to have latent TB infection in San Francisco, but only an estimated 23% are aware of their diagnosis and only 13% have been treated for their infection. This leaves a large opportunity gap, a large number of people who would benefit from diagnosis and treatment of latent infection before it has a chance to go on and develop active TB disease. Next slide. One way we're working to address this opportunity gap is by expansion of newcomer screening in the San Francisco TB Clinic. TB Clinic has long had a program for the evaluation of arriving immigrants who are classified as having a high risk of TB during their overseas screening, during their health evaluation prior to arrival. However, there's many newcomers, including humanitarian parole and asylum seekers, who don't undergo this pre-arrival health screening, who would benefit from getting TB screening once they're here. In 2022, the Newcomers Health Program and TB Clinic started a collaboration to screen humanitarian parole seekers for TB. It's a screening that's similar to the TB screening that happens overseas for other incoming immigrants. The volumes of newcomers screened this way has increased year over year and has also provided opportunities for linkage to primary care and also immigration and other services through the Newcomers Health Program and the Asylum Seekers Health Services Program within Population Health. Next slide. The TB program interfaces with many different organizations providing care and services to individuals at risk for TB. I've shared here a number of our key partners, including the UCSF Center for TB and the UCSF Asian Health Institute, Asylum Seeker Health Services, Maternal, Child, and Adolescent Health, San Francisco Unified, Head Start, the Promotores Network, shelters, and substance use services. I wanted to respond to a question asked earlier today by Commissioner Gerardo regarding TB screening for staff with these partners. Workers in most CBOs, FQHCs, and SF Unified are not required to get screened annually for TB, although in many of these organizations there's a baseline upon hire TB screening requirement. So there are clinics that voluntarily screen annually, particularly community clinics that serve higher risk populations sometimes opt to do annual screening of their staff. But for those other organizations, for schools and those other organizations, the requirement is for screening on hire. And we have provided technical assistance sometimes to help them make sure that people can get connected with those services.
Yeah, just a question based on what you just said. So can you let us know the reasons that it's not required annually, given the locus of this and the transmissibility?
So TB screening services, there are a lot of protections in place in terms of being able to serve individuals at risk for serving people or individuals at risk for TB. The highest risk for workers is when they're in enclosed spaces with poor ventilation, with a population that has high risk and maybe doesn't have access to services for screening. The CDC has guidelines for prevention of transmission of TB in certain settings like this, particularly in healthcare settings, as well as congregate settings like jails and prisons. So in those highest risk settings are where annual screening is recommended when an institution has a certain case volume or higher volume of TB cases. So most acute care hospitals and certainly prison services, which is required by law, have annual screening programs for their staff. And the CDC guidance was updated, I believe, in 2019 regarding the frequency of screening and to tailor that to basically to tailor that to risk, whether there's just baseline screening or annual screening. So in San Francisco, one of the things we've done is to work with our hospital partners in acute care settings to make sure that they're focusing their screening activities on people who have direct patient interface, not just like, working in an administrative role with no contact with the public and maybe have risk that's similar to other office workers in San Francisco.
And not spending time in those closed spaces where it can be transmitted?
Right, exactly. So I think, the requirement for TB screening is, especially at hire, is partly to protect the worker and also to protect the public. And really the prevention role of this screening is less to do about catching a TB case in the moment that someone has developed active TB, because remember that lifetime risk, it sort of plays out 5 to 10% over the lifetime of the individual. But if you, through that screening, are diagnosed with latent TB infection because you have a positive test with a normal chest x-ray, then that's an opportunity for that new worker, onboarding worker, to get treated for latent TB infection. And that's actually one of the things that will reduce the risk of TB for the individual and for the population. So I think when many of these laws went into place that required screening, the focus was not necessarily on that prevention, but with time and with the recognition that now that we're in this situation where the incidence is lower, that this is an opportunity to further get us toward TB elimination. identifying people with latent TB infection and getting them treatment.
And so are the steps that seem rational in the context that we're in, are those steps being taken that are not necessarily within the current CDC guidelines?
Yeah, so actually the CDC guidelines, when they were updated in 2019, one of the new parts of the guidelines for health worker screening in particular was to introduce a strong recommendation for treatment of latent TB infection if it was identified. And this is something that we've definitely been working with hospital partners and healthcare partners to emphasize, to get those to either be able to be treated in their occupational health clinics or to connect them with primary care services that they're eligible for, and get them treated for TB, for a latent TB infection. So that's something that we've worked a lot with our occupational health partners on for people onboarding into these roles.
Sounds like it's not required, though.
Treatment of LTBI is not required to start work. It's not part of the legal regulations that in California to start these roles. The legal requirement is to be evaluated for TB, whether that's through a risk-based evaluation or just a test for everyone, the way it's done for healthcare services. And once active TB disease has been excluded, they get cleared for work. And then it's really up to the employer, the occupational health provider that sees that patient to help them understand that even though they're cleared for work, they're still at risk for developing TB disease and encourage them to get treated for the latent infection. But it is not mandated.
Interesting.
Yeah, people who've been diagnosed with that latent infection, if they're in one of those higher risk settings, like a healthcare setting, they are required to get annual TB, everyone in those settings is required to get annual TB training, and part of that training includes how to lower your risk. And how to lower your risk if you've been diagnosed with latent infection would be to get treatment. And that treatment, so that treatment is recommended and education is provided, but it's not required.
Thank you.
Yeah. So if you move to the next slide, I wanted to highlight some of our partners here. We do regularly partner with FQHCs, particularly ones that are serving populations at higher risk for TB. And if you want to move to the next slide. So I wanted to talk about a couple of partners that we've been working with in the recent past. So Northeast Medical Services is a federally qualified health center with its flagship site located in Chinatown. And it provides culturally and linguistically sensitive care to primary care to its patients. We've provided public health detailing and technical assistance to NEMS on projects to optimize latent TB infection care, as well as active TB disease early diagnosis and detection. One of the projects that we worked on together was to improve adherence to American Thoracic Society guidelines for sputum testing. With the support from public health, they were able to achieve a 3-fold increase in guideline adherent sputum testing in 2023. And in recognition of these and other efforts to diagnose, prevent, and treat TB, NEMS was the recipient of a TB Elimination Hero Award in 2023 from the California TB Controllers Association. We can move to the next slide. Another FQHC that we partner closely with is the Mission Neighborhood Health Center. They also provide culturally sensitive and linguistically appropriate care for the patients that they serve. And the San Francisco TB clinics collaborated to provide consultation and support, as well as latent TB follow-up for complex cases. Together with the Public Health Lab, the TB program has collaborated with Mission Neighborhood Health to expand access to TB blood testing, which is more accurate in people who have received TB vaccination in their country of origin in higher incidence countries. And the Mission Neighborhood Health Center also developed a program for community health worker outreach, and with some technical assistance from the TB clinic, they were able to also share best practices with NEMS that had also developed a community health worker outreach program. So we were able to facilitate some of that best practices sharing. They were able to demonstrate a 20% increase in TB testing completeness among their primary care patients who are at risk for TB in 2024. And they were also recognized by the California TB Controllers Association as a TB elimination hero for these efforts. Next slide. In addition to community clinics and federally qualified health centers, the TB program partners with large health systems in San Francisco. We provide consultation and referral services for TB and complex LTBI patients, and also clinical training in the TB clinic and in-service training for providers and staff at UCSF, Zuckerberg, San Francisco General Hospital, and Chinese Hospital. We've assisted with the development of staff TB screening policies that you alluded to in these health systems, and provided consultation on implementation of the updated 2019 CDC guidance. We've also helped with expansion of TB blood testing for use for staff screening as well, because many staff also have a history of BCG vaccination, which makes that TB blood test a more accurate test for them when they're being tested and screened for TB. We've also provided technical assistance for the adoption of rapid molecular testing to get earlier diagnosis of TB in these hospitals. And we're collaborating with the OTOP program at San Francisco General Hospital on integration of TB and TB prevention services inside their substance use treatment program. Next slide. I wanted to thank the program staff that developed the data for these slides, Laura Romo-Timmy, Jose Gonzalez, and Camara Valdez in our epidemiology and surveillance section. And of course, the whole TB prevention staff and our partners whose work this represents. I'm happy to take any questions.
I just want to say thank you for the presentation and for engagement with my questions so clearly, and for a clear PowerPoint, a clear slide presentation, and as always, at the top of it, including the org chart and where you sit. It's really, really helpful to us and to the public who can access these documents as well. So thank you.
You're most welcome, and I should also thank my my partners here in Population Health, Eddie Sita and Suma Jane, for their help with preparing this presentation.
Very much appreciated.
Thank you.
I have a couple more.
Oh, yes, of course. Sorry.
Sorry, I have a couple more questions.
Yes.
So I wanted to ask too of newly arrived children and adolescents with their families. I was at the NIMS pediatric clinic and for a bit, and I don't believe, or I hope I may be wrong, that those kids are routinely screened for TB as in their well-child checks or in the clinic. And I'm wondering if, in fact, for whether or not it's, NEMS or, Mission Neighborhood, et cetera, if, in fact, that's any kind of a protocol?
Yeah, so the Northeast Medical Services has identified this screening of newcomers as a high priority and, a care gap. And they actually applied for, in collaboration with UCSF, a federal grant to improve their detection and screening services. So they actually have a large implementation study that they're working on right now to both assess completeness of screening and testing for newly arrived newcomers, people born in high incidence settings, including children, and also getting them through those steps of diagnosis, which requires a chest X-ray if the test is positive, and treatment. So I know that this is a big focus and priority of theirs, and I actually think their screening rates, that they've shared in the past with me, that their screening rates in the pediatric clinics are the best. And so some
Okay.
of their practices, they're trying to model on what they're doing in those clinics.
Which is great. Then my other question, and because I certainly don't know, because I work at CPMC, and it's, required testing every year. And I don't know if there's only one kind of test or whatever, but what we had is, the under skin, and it's read 2 days later. Is that time frame for people being screened and they have to return to have it read an impediment to the return, or is there any other kind of test that is more immediate?
Yeah, so I mean, that's a really good question. And this is something that we've been providing in terms of technical assistance for hospitals doing these screening programs where they do have staff interfacing with patients in a higher risk context. I'm a big proponent of using the blood test. The CDC specifically recommends it in certain settings. And one of the most important is people who have been BCG vaccinated, meaning they got a vaccine for TB when they were a kid. We don't do it in this country because there's some risks to that particular vaccine. It's a live vaccine, and it is done in countries where there's higher incidence, and it protects young children from disseminated TB. It doesn't do such a great job of protecting adults from the transmissible form of TB. So BCG vaccination, if people have been BCG vaccinated, the blood test doesn't cross-react with that the way the skin test does. And for those individuals who make up the vast bulk of people who get TB in San Francisco, the blood test is a better test. And for me, that is a good reason to recommend it in any of these screening programs. And also, the CDC recommends that blood test be used preferentially for people who are unlikely to return for a read. And I think those are sort of the two main settings: people who've been BCG vaccinated and people who are unlikely to return for a read. Some hospitals that I'm aware of, not in San Francisco, but have implemented the blood test because when they did like a cost analysis and took staff time cost into account, they recognized that there was actually cost savings to doing the blood test compared with the skin test. But the test itself is more expensive than the skin test, and so there are hospitals that continue to opt for the skin test.
So let's just say at the NEMS Peds Clinic, what do they do? Do you know? Is it the skin test or the blood test?
So NEMS is still capable of doing the skin test, but they have actually, one of the priorities in their project has been increasing access to the blood test. So initially they ramped up screening using a commercial lab, and then they decided that it was going to be more cost effective and patient-centered to be able to do it in-house in their lab. So they bought a machine to do this and and are certified to be able to do it in-house for NEMS. For Mission Neighborhood Health, they also wanted to ramp up screening, both in their pediatric and their adult newcomer population. And we worked with them in the public health lab to get them access to the blood test through the public health lab for sites that didn't already have access to it through the CPMC, because I think they have one site that's like near or on the Mission Bernal campus. And
It is, it's right there.
right, so I think that site, they already had access to it through CPMC, but at the other sites, it was a challenge with using commercial labs. So we partnered with them to expand their use of the public health lab to be able to get that.
Great, because I'm just wondering if a parent's going to bring a kid back 2 days later, to have it checked.
It's very challenging.
It just,
time
okay.
off of work, time out of school.
It's fairly rapid then, the blood test?
The blood test takes a little bit longer turnaround, but it doesn't require a second visit. And actually for kids, of all patients, if they've been BCG vaccinated, they have a higher rate of false positivity because their vaccination was recent. So it's especially important for kids born overseas to get that blood test, because it's really just a more accurate test for them, and there'll be fewer false positives, fewer chest x-rays that are not needed. So the blood test really is important, especially in that pediatric population.
Okay, which will lead me to my next question, or just discussion, it's not really a question, is I just read prior to the meeting the case study, which was amazing, on really what you were able to do in partnership with NEMS and the significant difference you were able to make in just what the protocol is now, which I thought was, I mean, statistically and just, I mean, it was impressive, so to speak, you know. So based on this, and yes, it was just published, I think, too, and especially where now there's what you were researching, what you had put together on figure 2 in this, you know, is more of, I mean, a protocol of going forward. And I laud your, you know, being able to do this. Where do you see then the implementation or of what you are able to find in this collaboration going forward with the protocol and implementing it, let's say even within DPH clinics, et cetera?
Well, part of why we wanted to publish this case study was to be able to share that best practice both locally and, you know, with our partners elsewhere in California and nationally. Development of that algorithm was really important for implementation in the NEMS clinic, which had already recognized TB as a priority for their population and really centered it. You know, I think that there's a kind of a crowded field. There are many health priorities, and sometimes it's hard for clinics to be able to give as much time as NEMS gave in developing this algorithm. So the goal is to take this kind of algorithm and be able to share it with partners, so they can have some of the steps already laid out in terms of how to understand some of the stumbling block points, particularly the one that was identified that got focused on in this study was with chest x-rays. If you get a small abnormality on the chest x-ray, what is it? Is it indicative of TB risk or not? And that can be a barrier to providers moving forward with offering that TB preventive treatment, the LTBI treatment. Or if they're not sure what the next diagnostic steps are or where to refer patients, that can be a stumbling block. So having a decision-making aid like that can be really helpful. We also identified that having standardized language in the radiology reads was very helpful as well. And that was kind of a moonshot of like, you know, we should work with our radiology partners to try to help standardize some of this language in the reads to support providers to be able to make those decisions and get that preventive treatment. But the goal is to share this with other settings.
Which I think is great. Is there a thought, or I don't know what, of taking this and then I guess training and implementing it in the DPH primary care clinics for a start, or to see getting more data and what the glitches might be, or something similar to that?
Absolutely. So I'm actually currently discussing this with Albert Yu and Joseph Pache. And one of the places that we're going to start is seeing what data is available about the completeness of this testing right now in the San Francisco Health Network primary care clinics, and see if there are gaps that can be evaluated and addressed based on the data that we have. We've already done some small projects. We developed an order set, so bundled orders in our electronic health record system to facilitate providers getting the diagnostic workup done, linked to guidelines, and have those treatment regimens pre-populated with the correct dosages and number of refills and monitoring labs to make that easier for those clinics. I think if we identify that there's a need in the primary care clinics at the health network, that this is a gap, the next step would be to look at sort of a multidisciplinary team approach where some of the screening happens before you get to the provider, and the provider would really focus on that difficult step of doing the health exam and interpreting the chest x-ray and getting to those next steps in patients who are at risk and have a positive test.
Okay, so, and I don't mean to be pushy here, but let's just say Chinatown Health Center could, based on your PowerPoint, that in Chinatown is the highest risk area identified in blue on your slide. Could this be piloted at that health center, so to speak?
So actually, Chinatown Public Health Center is one place where even before we were in Epic and had sort of Epic-related workflows, they had identified this as a priority and had nursing-driven protocols in place to do this kind of testing. So I think Chinatown Public Health Center has kind of been a leader for TB prevention work. They also had a federal grant similar to the one that NEMS has now to do some of this work. So it has really been a focus in Chinatown Public Health Center. Since that study, we are now in Epic. This changed a lot of our workflows, and I think we can use that to sort of amplify some of those protocols that are in one clinic to other clinic sites that could benefit from it. So that's something we're definitely working on with the health network.
Okay, that would be in your next report coming back to us. The follow-up on that, I think, would be appreciated. I guess it's just my own clinical frustration when you have something like this that, the implementation can be, so wonderful, but, human beings get involved and it's kind of it's a wall to a certain extent. But, taking what, Chinatown Health Center had done and what this is and what you might be able to do further, let's say in the Mission or where those higher incidences are in like at Southeast or something similar to that, I think would be really helpful for us to even further understand the work and the amount of time and research we're also doing for implementation. So if we could even just in your next report, I'd like to not have it just within you and your department, but throughout, taking what you've learned through this and being able to implement it. So thank you.
Thank you.
Dr. Grace, may I ask a quick follow-up question? Commissioners, I hope it's okay I do this, but piggybacking on Commissioner Christian's early questions,
Yes.
I'm curious if workers who work with populations who are HIV positive or otherwise immune compromised have different standards for TB testing, screening, or treatment.
So it really depends on the type of worker. So for health workers, yes, across the board, they need to be screened for sure at baseline. And then it depends on how much TB is in the population that they serve, whether or not they would be needing annual testing. If you're talking about non-health settings, like for example, housing or other settings, repeat annual testing is not required in like non-health settings for housing, whether the people in the housing have HIV or not. So I hope that answers your question.
Oh, it does, and I appreciate it. And Commissioners, I hope that was, I thought that might illuminate a little bit the extra population.
Yeah,
So
thank you for the questions, Mark. I still have more, but I'm not going to bother you with them. But with respect to what Mark just said, as somebody who is not a clinician at all, It seems odd to me that it wouldn't be required in a housing setting, but it would be required in a clinical setting for particularly if we're talking about people at a heightened risk for, I don't know about developing or being likely to catch it if the transmission is possible. But if they have an underlying health issue that is an immune issue, it seems odd to me that in a housing setting, people would not be required to test annually. Can you just help me understand that a little bit?
Well, nothing prevents a housing setting from putting additional requirements in place, but the California Health and Safety Code and the California Code of Regulations doesn't require it in all housing settings, or even in housing settings that specifically serve like a subpopulation on an annual basis. I think this might have partly to do with that very low risk of, like, once people have been screened and noted not to have active TB disease, even if they have a positive test, the likelihood of going on to develop active disease is sort of this lifetime risk. And the focus is less on testing, but more on encouraging treatment. So I mean, though that,
I understand.
I guess that's how the regulations were developed. I see what you're saying in terms of rationale, and when outbreaks do happen, they are more often in less regulated housing settings. So, for example, like a private single room occupancy hotel setting where it's not part of HSH and doesn't have the testing requirement for people entering into housing. People who are living doubled up, maybe multiple families in one apartment, but it's not a shelter and it's not a housing setting. So these are the types of places where we more often see transmission among people, and less in settings where people are getting baseline testing. And usually in those more regulated settings, they also have better access to care, and getting referred more promptly if they develop symptoms.
I suppose that, I mean, the regulations are the regulations, they must be obeyed, but there's nothing preventing any jurisdiction from being more strict or more proactive with trying to suppress the disease.
Yeah, for sure. I mean, we haven't seen in San Francisco transmission in these populations. We do have a requirement for our shelters. So for entry into our shelter programs locally, we have a requirement for being screened for TB, and then you get a shelter clearance for 1 year. And then you are required to screen again if you're re-entering shelters. Because this is entry into shelters, it's normally temporary, so it would be like in and out of the shelter. So to re-enter the shelter, if it's been more than a year since their last TB screening, that would be required. So we do have that local regulation, and we do have that also for our behavioral health programs. But it's not like a universal requirement for housing specifically.
And if someone tests positive, if that's the correct way to say it, there's treatment that doesn't cost them anything.
If someone tests positive so if they are entering into a behavioral health or drug treatment program or a shelter, they're eligible for free treatment at TB Clinic if they're in San Francisco. They often have access to free treatment through other means as well. Like if they are Medi-Cal patients, they would be eligible for free treatment through their primary care provider. Many of the behavioral health sites also are linked with a clinic that provides care for their patients, whether that's primary care or care associated with the behavioral health treatment program. So they are eligible for free treatment. Engaging people in care is that is the core of our work with these community partners, and helping people prioritize it when, the reason they're entering a shelter is not because they're feeling sick from TB, because this is a latent infection, but because, they're really just focused on the very basics of survival. And so I think a big challenge is helping people prioritize that preventive health when they're struggling in that setting. But certainly providing free treatment is something that we do in the TB clinic, and try to support our partners that way to be able to prioritize it.
I understand the approach and I appreciate it. It would be, I think it'd be useful when you give these presentations to ground us, ground the listeners in the philosophy and the approach and why the approach is what it is. Because there are people who are not clinicians and who don't work, not healthcare providers of any kind, or maybe not even in a helping field, and don't have the experience about the best way to engage and help a person do what is best for them. It might be, I think it would be helpful to remind the rest of us who are not in your field about why you approach things the way that you do and why it's an important approach to have. So, and thank you so much for your work. It's so critical, and really proud to be a San Franciscan based on the presentation. So thank you so much.
Thank you, commissioners.
Thank you very much. And I know we've kept you in.
That's all right. I can answer questions.
Your presentation was great. This information was great, which also sparks us to oftentimes just want more information to really understand, as Commissioner Christian said, your work. And so thank you very much.
Absolutely. Thanks for the opportunity, and we'll follow up with the suggestions that you made.
Okay, thank you.
All right, we can move on to item 4, the BHS internship pipeline update.
Hello, commissioners. Thank you for having us. And my colleague, Katie Pacino, is online. She's actually out of town, so she's going to be presenting the majority of it. I will be covering parts of it and answering the questions that Commissioner Gerardo asked for, and then we'll take any questions after that. I just want to say Katie's only been with the department for about 4 months, so if there's questions that she cannot answer, I'll be here to try to help also. Okay, I'm going to turn it over to Katie.
And extra thanks to Katie for popping in the meeting while you're not at work. We really appreciate it.
Oh, it's my pleasure. Thank you guys so much.
I'm pulling up the
Hi,
presentation.
everyone. Oh, wonderful. My name is Katie Pacino. I am the BHS internship coordinator, and as Danielle mentioned, I've been in the position for just under 4 months. And so, yeah, I'm going to be doing this presentation with Danielle. And we are a part of the BHS Justice, Equity, Diversity, and Inclusion Department. Next slide. So what we're going to be going over during today's presentation is just a multi-year glance, looking over what the last few years have looked like, a closer look at 2024 and 2025 civil service interns, a look over at last year's set of interns, specifically who received the Multicultural Student Stipend Program, and some of the highlights, and then some of the challenges and opportunities that we are facing currently. Next slide. So if you're looking at an organization chart, you can see, if you kind of zoom in, next slide zooms in, you'll see where there's behavioral health, and I've put some boxes around it. So behavioral health is the department that I'm in within San Francisco Department of Public Health. Jessica Brown is the director of JEDI, and so some of our interns fall into that group. Some of the interns fall into the system of care. And then we have some that are in jail health. And we do have some interns in primary care as well that participate in various parts of internship for behavioral health. Next slide. All right. So an overview of 2022 to 2023, there were 23 civil service interns or trainees that completed placements at 12 different BHS sites. During that time frame, they had added 2 new schools / programs, and they did add 1 undergraduate placement. During that time, the budget had been expanded to $150,000. And they had 60 stipend awardees, 9 of which were civil service, 5 were DPH civil service, and then 46 were with our community-based organizations. The next year, 2023 to 2024, there were about 18 civil service interns / trainees, and they were at about 10 different sites. They found that there was a growing demand for online schools. The budget was a little bit lower at about $100,000, and there were 42 stipend awardees. 14 of them were at BHS sites, 25 at DPH sites, and then 3 of them at CDOs. And then this year, we've got 26 civil service interns / trainees at 19 different sites. Of those 26, 22 are with BHS, and 4 of them are with primary care behavioral health. We've added another school, and same budget as last year for the multicultural student stipend. And the application cycle for the multicultural student stipend has officially opened and closes on November 1st. Next slide. All right, so this year, our BHS interns, we have 22 interns just at BHS at 15 different sites. And here is a list of all of the different sites that we have interns at. And so Office of Coordinated Care has taken a few interns with their Permanent Housing Advanced Clinical Services, the FACS office, Bridge and Engagement Services Case Management, Care Management Team, or the BEST CMs. They also have a Bridge and Engagement Services Neighborhood Team. We've got Shelter Behavioral Health, Chinatown North Beach, Mental Health, Foster Care Mental Health, Comprehensive Crisis Services, Sunset Mental Health, Family Mosaic Project, Jail Behavioral Health, Mission Mental Health, African American Alternatives, OMI Family Center, SS First, which is at an intensive case management program at South Market Mental Health, and then Justice, Equity, Diversity, Inclusion JEDI has a couple interns. Next slide, please. Just a degree breakdown of this year's interns. 4 of them are receiving masters or working towards Masters of Marriage and Family Therapy at University of San Francisco, Alliant International, San Francisco State University. 1 is in a Master's of Counseling program at SF State. 3 of them are doctorate students in psychology, and they are students at University of San Francisco and the Wright Institute. And then 14 of them are receiving and working towards Masters of Social Work at schools including Cal State East Bay, San Francisco State University, Columbia University, San Jose State University, and Alliant International. Next slide. So last year's cohort included a growing number of civil service employees that were going back to school and pursuing graduate degrees to advance within the Department of Public Health. And this year, we're seeing even more of that growth. And so this year, we have 1 current health worker 3 who is working towards getting their master's in social work, and they're on track to finish to be able to apply for positions as a 2930 within the Department of Public Health, 2930 behavioral health clinician. We have 1 court clerk 2 employee who is going back to school getting their master's in marriage and family therapy, who is also on track to becoming a 2930. Next slide. There's one community police service aide who works for San Francisco Police Department, who's going back to school, getting their master's in marriage and family therapy, also working on track to become a 2930 behavioral health clinician for the city. And then we also have a DPH RAMS peer counselor who's been placed with DPH sites, and they're working on getting their master's in social work and on track to becoming a 2930 behavioral health clinician as well.
Katie,
Next
before you
slide.
move on, is it okay? I think Commissioner Gerardo had a question. The 2930 position classification is for a master's level behavioral health clinician, right? And then there are others for folks who have a doctorate?
Yes. So individuals who have a doctorate, it's called, I believe, a 2574 clinical psychologist. And 2930 refers to any behavioral health clinician who is unlicensed, such as associate social worker, associate MFT, associate clinical counselor, as well as licensed. So licensed marriage and family therapist, licensed social worker, and licensed clinical counselor.
Thanks for that clarification.
Thank you. My pleasure. All right, so now I'm going to talk to you a little bit about the Multicultural Student Stipend Program. Some of this information is from before I came onto the team, and so some of this is historic information that I was able to gather to present today. But the program was established back in 1988, and the total funds for this year are about $100,000. The stipends range anywhere from $1,000 to $5,000 per awardee. Last year, there were about 42 students who received these stipends. Next slide. So when we broke down the awardees from last year, when you're looking at gender identity, you can see that about 69% identified as cisgender female, 19% of the awardees identified as cisgender male, 7% identified as non-binary, 3% identified as genderqueer, and then 2% just identified as queer. When these questions were asked last year, they were asked and the students were able to fill in the answers. And so I wanted to respect whatever the students filled in. And so as we go through these slides, you might notice some categories and have some questions about what each category was. And out of respect to however the student identified, that is how I placed them. So you'll notice non-binary, genderqueer, and queer I kept separate because that's how those students identified and wanted to respect that. Next slide, please. All right, and so when we look at the race and ethnicity breakdown of the students who received awards for the Multicultural Student Stipend Program, there was about, the largest group was about 36% identified as Hispanic, Latino, Latina, Chicana, Mexican American, Chicanx, Latinx, or Salvadorian American. About 31% identified as Asian, Chinese, Bangladeshi American, mixed Indonesian, Taiwanese, and Filipina. We had about 14% being the third largest group that identified as white, Jewish, Southern European, or / serial migrant. Then there were the 7% was the next largest group, and they were individuals who identified as Black, African American, or Jamaican. Then there were 5% that identified as Middle Eastern Jewish, 5% that identified as mixed, biracial, or Afro-Indigenous, and then 2% did not disclose race or ethnicity. Next slide. So here we can see a breakdown of where these recipients were going to school. So you can see the largest group being San Francisco State University with 24%. Then we've got USF, University of San Francisco, at 19%. We've got UCB, which and at about 14%, Wright Institute, and then Yeah, we've got a myriad of other ones: Palo Alto University, Grand Canyon University, CSU East Bay, Columbia, CIIS, Bellevue University, University of Miami, Touro University, and Smith College. Next slide, please. All right. We also inquired about language ability, and so about 31% listed that they speak Spanish. 31% listed English only. We had about 16% spoke Mandarin. Then we have 8% Cantonese, and 2% for Nepali, Tagalog, Taiwanese, Portuguese, French, and Bangla/Bengali. Next slide. All right, Danielle, would you like to step in for challenges or?
Sure, I can step in. So challenges, no worries. So BHS has transitioned from Avatar to Epic, which is a platform where we keep our health records, right? And the problem is with the credentialing of our interns has been a challenge, whereas with Avatar, it was quasi simpler than what it is with Epic. There's a lot of hoops that has to go through. So we are trying to resolve those issues as we go through. There's quite a few vacancies among supervisors and behavioral health clinicians that have impeded some of our sites that have historically hosted interns due to lack of supervisors that meet the University and our Board of Behavioral Sciences guidelines for this year. So trying to get people not only credentialed, but to get them to where their license allows them to supervise is another challenge. And then just the total transition to Epic as well. And all the stress that's been involved in that has contributed to some of the sites saying, thank you, not this year, we're not going to do interns. And that's where we are right now with the challenges. Next slide, please. Our opportunities. So we do have what's called, it's labeled as a 9910 public service trainee position, and that position has been launched to bridge the gaps between the interns that are actually here that have graduated into regular civil service positions. This program is overseen by our director, David Nish, which is of operations. As of right now, there was 20 positions that were funded for, and last time I checked, 15 of those positions have been filled by clinicians, interns that are trying to become 2930s. The issue is, of course, hiring within San Francisco has caused the issue, as well as behavioral health, Board of Behavioral Sciences actually getting them their license number. And so this was a program that was built to fill that gap until they can get their numbers and then go ahead and apply for regular city and county positions. So it's basically a retaining process that we're looking at. Jedi pairing, culturally congruent interns with our CBOs. A lot of our CBOs have asked for cultural congruence, like language capacity, and or clinicians that may look like the representation of who they're serving. And so we're filling that gap. The National Health Service Corps is expanding their stipend program for interns and traineeships, and what we're trying to do is actually create a template for our clinics to apply for to retain their clinicians, as well as them getting stipends while they're doing their internships, as well as with the Healthcare Access and Information, the HCAI also. Our internship is also expanding to bachelor level, where we're trying to get bachelor level graduates in as health workers and or health program coordinators to fill those open positions. And we're also expanding to the BAPIC, which is Bay Area Practicum Information Collaborative. We do have some, but we're trying to also extend that program as well. That's the opportunities. there were questions that I'd like to go over, and if you all have any more questions, we'll answer those as well. So the first question was with the website for internships. We do have a dedicated website. It's called the Behavioral Health Services Clinical Graduate Internship Program. That's on SF.gov. And so interns can go there and look at that and apply. And that's how we get those interns that are applying to the programs, right? As well as previous contacts. Word of mouth has been a good way for it as well. Slide 8 for what is behavioral health. Oh, go ahead. Yes. Of course. No. Yes.
Thank you. In the past, I mean, this is great progress, believe me. I'm fully aware of that. But I know when Dr. Cunnins came in, it was one of my concerns with the website in trying to have the, because the internships previously were all over the place. And so it was narrowed to what it is now. But initially on the website, the positions of what it was were listed, okay? So if you were interested in whatever was going on in the jail or whatever, there were, like 20 or 30 sites. So currently, you don't know what it is. This is where I guess I have a concern because I also supervise interns and I've sent many then to the website, but there is significant frustration and they give up because they want they want to know, well, I don't know what I'm applying for. Why am I giving them the information when there's 5 or 6 different categories? And I don't know. So is it, and so at least the ones that I've sent came back to me and say, I give up. I don't know. And so I'm just concerned.
Yes.
If I am, a pre-doc or postdoc, and yes, I'm very interested in public health, but I don't know, I don't want to do this. Help me understand this, because I'd rather continue to try to send people without saying they're frustrated that this doesn't work. I'll go to some other county and see what I can find.
Sure. Katie, did you want to
I may be able to, I might be able to jump in on this. So I'm not quite sure which website they're being directed to, but the website you described where they have a list of all of the different sites and what they do at each site, that still exists. I manage that website. And so that's usually the site, as I've been coordinating with all of the universities, that's the site that I've been showing all of the students to go to kind of figure out, what site would I be interested in working at? Is that the
So
site
that's
you're
what I
referring to?
did. That's what I'm asking. So I went on it myself yesterday to, and I put in SFDPH, BHS internships. And so I was sent to one site to apply to there were 5 or 6 different categories that I could apply to. If you're interested, I don't know, it was maternal child health or jail or whatever, apply. I didn't see anything on that to go to another site to see what in fact under, let's just say, maternal and child health was being offered as the separate so-called jobs or internships. So is there another place to go?
There's no other place to go, but I think what I'm hearing is that someone may be looking at a specific area that they may want to work in under DPH.
In
maternal
behavioral
child
health,
health, yes.
whether they want to work with kids or jails or
Right.
whatever. but they don't know what is being offered within those sites until they submit their name and they apply, and then pray God somebody gets back to them. I mean, it just, whatever. That's my problem.
So I think it might be a little bit of a disconnect because technically Katie manages all of that.
Right.
All of that stuff. And Katie's the one that gets back to them. I think what may have happened was there may have been a gap in time between when Ryan left and Katie came aboard and nobody was overseeing that. That could be one explanation, okay?
Okay.
The second explanation can be that people may be trying to apply for a specific internship and it may not be listed, right, as an opportunity. Because as was presented, some of our sites had said, yeah, no, not this year. Whereas it was available before,
Right.
and it may not be available now.
Right.
I would like to propose that if you run across, and if people are interested, please give them Katie's information or my information so that we can get back to them
Right.
more exponentially.
I agree.
Okay.
But is there a way
Yes.
on the website to differentiate or to post, let's say, because you just said 15 out of 20 slots were filled or
For
whatever.
the 9910, which is after they graduate and they
Okay.
want to apply for city and county.
Oh, okay. So
That's different.
forget that one. What I'm talking about is I've got a postdoc. Is there a way on some website, like a secondary website that lists under behavioral, under maternal child health, under jail health, what the specific opportunities are versus just generic apply? That's all I'm saying. It just, I think,
Yeah.
I mean, because we all have a tough time getting behavioral health clinicians. I'm totally on board. I'm in your ballpark. But this is really too unclear from even where it was before, because the specific internship positions were listed. So somebody could say, yes, oh, they don't have anything under maternal and child health. But maybe they do under primary care. Let me see what's under primary care. So all I'm suggesting is the marketing isn't,
The best.
it's not the best. And I just think with, 22 or 25 internships, they could be categorized.
Yeah.
And once, they're filled or whatever, you delete, or something. So it's just, I think it would really be helpful, at least for those that I send your way.
So we will take that back.
Yeah.
Unfortunately, we don't control the website per se, but we can ask for that to happen and see if we can get any traction on that.
Yeah.
Because I hear you, and I agree with everything that you just said. I mean, you don't want to do a generic application process, and so.
No.
Yeah.
And I just think you might be losing some
Yes.
really interested people because
Yeah.
they don't know what,
They're applying for.
I mean, when you're finished.
It's true.
Could I jump in on the website piece here with a question? So I have, just with the website, the DPH website, I've experienced a lot of difficulty finding information that I want with a very specific request. For instance, there have been multiple times where I have searched for organizational charts for behavioral health or something specific. It will not take me to that place. And certainly if I get there, it's not because the website initially takes me to that. And so I don't understand why that is, but it seems to be a systemic issue because I can never find anything I'm looking for on the first search.
Commissioner, that's a separate topic, and we're going to bring that. That was scheduled for later this year, but we bumped it because the calendar change, but we're going to have a
topic
on the website so you all can navigate it and give feedback in general.
Great.
Early next year.
Great, I understand it's separate. I just wanted to say yes, and you're not the only place that this is being experienced.
Correct, and it has been escalated. So people should be aware of this. So just saying, okay.
And Commissioners, I can follow up, I'm sorry to interrupt you. I can follow up for this meeting with the minutes to the folks who are presenting, as well as Dr. Cunnins and Director Colfax. So it's showing, it'll support the staff and also show this is from the commission, this is feedback from the commission.
That'd be great because, our goal is to support you, and I don't mean to badger you, but it's like, I want to send more people who are very interested because I have 5 postdocs and they're all community health people.
Wow.
And so after they leave us, that they will say to me, because I'm on this commission, what about DPH? And because they want to do a postdoc or go pre-doc to postdoc. And it's like, but I can't find anything. And it's
That's
like,
fair.
so but I appreciate being able to push it up.
Yeah.
And why we're kind of,
And I will be responding to this when I go back as well. So just letting you know.
I appreciate that. I also want to know, and maybe Katie, in your presentation, what is a serial migrant?
Yes, I have that. for you.
Okay, because I'm like,
That was what a student typed in. They typed in, I believe they typed in European/serial migrant. And so I wanted to respect exactly how they wrote their racial identity. And so I just put that in a group.
okay, thank you.
Well,
Never
what
heard
it
the term.
is, there is a definition.
There
for
is.
it.
Oh,
Yes,
is there?
there is
Okay.
it
Oh,
is a
great.
definition.
Educate me.
And basically, it says someone who has moved to more than 2 countries and considers more than 2 places their home.
Okay.
That's what the definition came up as. So this person has considered themselves a serial migrant. We did not give them that term.
Okay, it's just that I'd never heard that before.
Yeah.
So
It was news to me as well.
I appreciate that. Okay.
Okay.
You to me as well.
Yeah.
The 2930 question also came up. Okay, so the 2930, I'm going to read this because it's fairly long, but Katie is well aware about it. I'm just hoping this is clearer for you all than us just talking. It determines the eligibility for psychiatric care and services. It evaluates information gained through interviews and collateral sources, makes determination on one several alternative procedures, completes appropriate forms, documentations related to intake, and makes pertinent determinations and recommendations for clients. We carry out and explain established methods and procedures to applicants, recipients, and others, achieve economies and/or preventing losses through careful and judicious interpretations of various legal provisions, methods, and procedures, and recommending assistance. We make regular contacts with applicants, recipients, their families, and others concerned, also with employees, other departments, and outside organizations, our CBOs, and gather, compile, and review an important detailed psychiatric, financial, personal, and confidential information. Nature of duty involves occasional exposure to accident hazards and disagreeable elements in dealing with mentally ill and emotionally disturbed persons. So basically, there used to be a term called psychiatric clinicians, behavioral health clinicians substituted for them. So we work with people on within mental health and behavioral health and try to connect them to services, stabilize them, and or treat them if we can within the auspices of a clinic, basically.
So what I understood you to say too, Katie, it's social workers, it's LCSWs
Yes,
and MFTs?
yes.
And is it licensed And they're licensed psychologists or not?
Okay.
No,
Yes.
licensed psychologist falls under 2574.
Okay. Okay.
So for the 2930 positions, they're usually LCSWs, LMFTs, LPCCs was licensed professional clinical counselors. Or if they have not achieved the licensing part yet, they are associates.
Got it.
All of that covers the 2930 aspect.
Great.
Okay,
Thank you.
all righty. Are there any other questions with that?
I had one more.
Okay,
On your bullet point of vacancies among supervisors,
yes.
is it possible to contract outside of DPH for a supervisor or not?
Yes, and the language is, so I think you all have heard of Proposition 1. So Proposition 1 allows a little bit more latitude under Behavioral Health Services Act than it did under Mental Health Services Act. But we are waiting for guidance from the state for the workforce education piece and the training funding opportunities to be able to get that in place. So the answer is yes and, right?
So you're looking then for the funding opportunities through the state to pay for the contract supervisors, correct?
Yeah.
Great.
I think you're all aware they've went from 5 buckets down to 3, so the workforce development bucket falls under what the behavioral health, but the monies are limited now. And so there's quite a bit of money coming down from the state that we may be able to apply for to be able to do some of the stuff that we're trying to do.
Great. My last was on slide 16, was you made great progress. And we would really like when, possible, or just an update on the opportunities that you listed
Yes.
to see the wonderful progress I'm sure you will make. But we all, just even using the national, the NHCS as, an interim, that's really creative, in trying to do things. But we always like to hear back on
Yes.
the opportunities or challenges, what progress you've been able to make and to further support your work.
We'll be happy to come back and speak again. No worries.
Okay.
Yes. This is all rolling out, so, as we progress, we'll be happy to come back and speak.
Yeah, it's just, and this was wonderful. It's just, I know of all departments in DPH, behavioral health is, one of the most challenged for hiring,
It's true, still is.
as it is for all of us. But I'm just, with, the great work, I just want to make sure that
Yeah,
those pipelines are there so you can get more folks too. So
thank you.
I really appreciate your presentation. Do you have any other questions?
I do. Thank you for the presentation and echo everything Commissioner Gerardo said about the importance of behavioral health workers and clinicians and the pipeline. So thank you so much for working on this. So can you just explain what multicultural student means and what its relationship is with that pipeline, support through this program, the relationship to the overall behavioral health internship pipeline?
The multicultural students stipend?
Right. Well, so page 10, multicultural student, what does that mean to DPH in this context?
I'm getting my slide, so hold on.
I may be able to speak on this. So
The
I
stipend.
believe that when we're looking at when I talk to the students about the Multicultural Student Stipend Program, the way that I talk to them about it is it's not just about the individuals that are applying. It's not just about the students and being multicultural. It's also about the clients that we serve. We're serving underserved populations. And so some of the questions that it asks in the application, it asks about language capacity. It asks about racial and ethnic background. It asks about competency in serving diverse populations and populations that are different from your own. And so I believe that that's kind of where the name came from. Danielle, if you'd like to add anything.
We also felt, because this was about the stipend program, a lot of our students that were coming in who happened to be from diverse backgrounds had no income at all.
Sure.
Right? And so under MHSA, they're like, yeah, no, this is part of workforce development, right? And so devised a plan to where we could at least give them a little something for the work that they were doing with the communities, right? And so that was part of it that happened, and that's why you see the range of 1 to 5,000. And basically, they had to apply for these funds, okay? And so I believe now Katie and I are talking about possibly, instead of them quote, quote, applying, because we do know the work that they're doing, trying to make it more equitable across the board to where they're doing the work. Let's look at how we can help support them to continue to do this great work, right? Because as you can see, some of them are traveling from distances, some of them are, not everybody's local, so to help them to be able to do, by no stretch of the imagination is a regular paycheck, but to help them to be able to do things that will help them continue to do this good work. That's basically how this program quasi got started. This was all under Jessica.
Yeah, great. I totally get that and understand it. And certainly the use of multicultural for various, as a descriptor for various reasons is, long and storied and great. I'm just trying to understand it in the context of this internship program and what does and how the department is conceiving of or defining multicultural, and you noted that a lot of it is based on the population that is unserved. I also wonder how much of it is based on the background of the person who is applying, which it sounds like a fair amount. It's focused on getting a widespread diverse workforce. And I understand, believe me, the need to target that effort and to look for people and make it easier for people to take the jobs because, given support. I also just wonder if there's a way to make it clear that the entire program is focused on serving all the populations that we have and serving the diverse populations and having a diverse array of providers. Rather than in this kind of narrow space, which is a necessary space.
Yes. So how I can speak on it, having supervised people that have gone through this program, is just about every intern goes through an interview process. And part of the interview process, as Katie just laid out, is specific questions around, number one, commitment, number two, the diversity that they have been exposed to and how they want to technically continue, because that's what DPH is, right? We serve communities, basically many communities of color, where their work has to be targeted towards the populations, right? So
Culturally congruent.
culturally congruent, right? And we have several programs that are dedicated toward cultural congruence as well. So we asked that to actually explain to them how this is an expectation, not a suggestion, basically. And as we go forward, a lot of departments that I have worked with, that I'm sure Katie has seen, we try to teach them towards that, right? Like the non-judgment piece and things like that. And for these efforts, this is what Jessica is saying, like they are dedicating a lot of time, energy, and effort to this. There should be some type of incentive to keep people to come, right? Outside of HCAI and NCHS, where that is also an application process, like what is DPH doing as well. So I'm hoping that I'm answering your question a little bit more.
Yeah, you are. It's very helpful. And I do wonder if, like, what the application process brings out regarding these questions and goals, right? And I'm assuming and hopeful that it asks questions about, getting people from underserved and underrepresented communities and populations to also be interested in and dedicated to serving underserved populations, and that the whole application process, no matter what someone's background is, teases that out
Correct.
and identifies people who are more necessary than others in some ways, just numbers wise.
Correct. So the chart that Katie showed, how there's dispersed, the dispersed populations, like Chinatown has specific needs, Mission has specific needs, Southeast has specific needs. We try to let them know that in these populations, within the city, there's all these different kind of needs. We cannot discriminate, so we
Right.
do not, but we do try to allow them and let them know that you may be working with these specific populations, and how comfortable are you being willing to challenge yourself to work with these populations if for no other reason you have not had exposure, right? And that's why it's so important for our workers who are working with these populations to supervise these individuals and to let them know, right? And that's why I know when I did it, we did have to turn away some interns because they were not, number one, either willing, or number two, wasn't grasping like the need for being compassionate to our homeless population, to our SUD population, substance use disorders and people who did that, to our populations that, have psychiatric challenges that you may need patients, right? So not everybody gets in, right? But the ones that get in show a different type of dedication to the work that we're trying to help them to do.
Thank you.
Just to maybe add on to your question, you had mentioned that of the 42, I believe.
Last year, yes.
Yeah, last year, that not all were from here. They were from other places or?
Yeah, other schools that are not necessarily in the 9 Bay Area counties, right?
Okay, and so are all these students placed someplace in DPH or they're in other places? That's where,
They're in behavioral health for the most part, and some are in DPH as well, yes.
okay, somewhere in DPH is where they are. And so, am I correct? Katie, I can see your face.
Yes. We also open it up to students who are placed at CBOs, so community-based organizations. So some of our DPH partners, such as UCSF Citywide, UCSF CAS program, Edgewood, these programs that are in San Francisco but aren't necessarily Department of Public Health but do receive funding from adults and older adults or various systems of care.
Right.
And then how do you market or advertise this stipend or this program, the Multicultural Student Stipend Program or Multicultural Student Program?
Yeah, I could speak on this one. So when I joined this team, I had a goal to try and meet every single one of our community-based organizations and every one of our internship sites. And I hit almost all of them. Some of them said, we don't have interns this year. Why don't you come later in the year? And then some of them, I just haven't been able to get in touch. But in those meetings that I've had with almost all of those sites, this has been something we've talked about. And there were many, many of our sites that had no idea we did this. And so I also created, when the application went live, I sent it out to all of our system of care. So our transitional age youth system of care to send out to their listserv. I sent it to our adult and older adult system of care listserv, and sent it to our children, youth, and family system of care listserv. And then I also created a separate email group as well of all of the people I met with and sent it to them individually. And so we're definitely getting lots of applications in. So I've already started reviewing. I'm hopeful that we'll see even more applications this year than we have in the past, but we'll see.
Great work.
I think, and if I can pick up on Katie's last comment there, the getting more applications and letting more people know about it. What kind of blasts beyond local blasts do you do? Like are they sent? Is this opportunity advertised nationally?
I would say it's
So
not
no.
advertised nationally. We're looking at a department of one, basically. And so until we can grow it a little
Sure,
bit,
yeah.
I would say not nationally, but the word is out that San Francisco Department of Public Health does take interns and does do stipends.
And so specifically, it came to mind, historically black colleges and universities. It would be, given what's happened to the black African-American population in San Francisco and where we are now, critical to let people who are focused on that cultural identity, to let them know that there are opportunities here. So that's why I said nationally.
I agree. I appreciate that. I appreciate that.
It's just a targeted.
Yes. And that I will talk with Katie about that, because I know that there are, for the HBCUs, there's contacts here in the Bay Area that we can send the applications to let them know, right? As opposed, we don't have to go out there, they're here, so we can send it out and have them also disseminate it the same way you said, right?
Great.
And that will make our work a little easier.
Yeah, yeah.
A little easier, because I mean, it is challenging to try to get it to areas that we know need the most service, but we have the least applicants available. So thank you for that suggestion.
Oh, sure, absolutely. And the other question I had is, so it's my understanding, correct, just, correct the record here, or all the clinicians in DPH are civil service, right?
Yes.
Okay.
Well,
When they're
except for the
hired.
9910s.
Okay, the
Right,
99.
the 9910s are not yet fully civil service employees. They're still considered interns.
Okay, they're interns, but if someone is a full employee at DPH, they are civil service.
Correct.
And so that's why you're calling it civil service interns, trainees, because the ultimate goal, if you're hired, you will be civil service.
Correct.
And okay,
And that's our goal, right? So the 9910s are even targeted. Like, we have communities in San Francisco that are, even though they have clinicians, they don't have clinicians that look like them. And a lot of the requests have been culturally congruent. We would like clinicians. So the 9910s are kind of targeting the interns that have already been here, had successful service under San Francisco, to go into these communities and continue to do their good work. And that's what we're looking at, right? And like I said, the last time, that was actually about a month and a half ago, we had filled 15 of the 20 slots with people that are representing the different community clinics that we have, not just general, not just, Laguna Honda, like literally at community clinics, like Chinatown, North Beach, like at Southeast, like at, Mission Mental Health. They're actually going to these communities and working in those communities. So,
And is there anything that a high school intern could do in this context where we could be bringing in or letting our students in San Francisco know that they can have a career here and they can see what it's like, even if there's no program that is actually rational? Is there an outreach to let them know, fairs or anything like that?
Could I actually jump in on this one?
yes.
This actually recently came up, and our HR has pretty tight guidelines on who is allowed to intern with Department of Public Health. And they have shared some of those guidelines, but basically high schoolers are not allowed unless they are a part of a workforce program, and there's only a few sites that manage that. And so I have the email from HR where they talked a little bit about who they would allow to do it. And there are specific schools that they work with. But any interns that come to Department of Public Health, we have to have an MOU with their school before we're allowed to take them on as an intern. And it can take up to 6 months to develop an MOU with those schools. They have to have a certain amount of insurance. They need to make sure that they meet the requirements that HR has. And so, yeah, they're working on growing for high schoolers. But yes, I know that is something that they're working on doing.
Yeah, there are a lot of barriers, and thank you for trying to work through some of them. And and I say this a lot. I just encourage all in any ways that you can to let the kids know from an early age that this work is being done, and it's being done by people who live here for people who live here, and it's something that they can do.
Yeah, I agree with you, and I agree with Katie. I talked to Katie about this. It's one of my pet peeves with city and county is that we want workers, but we have no mechanisms of bringing them in, right? And why not start at high school level? And we haven't been able to accomplish that yet. Haven't given up. We haven't been able to accomplish that yet.
Maybe there's a way to break through that barrier across the city and the department. But thank you so much for.
No worries.
The last question I had, I love your name, Jedi. And I wonder, is that something that has been kind of reconfigured and developed in the last couple of years, or has it always been justice? I love the fact that justice is first.
Yes. I would have to put that on Jessica and say that I'm sure there's a team. Katie, did you want to say something?
Yeah, actually, Jessica came up with it.
Yeah.
So our director,
Jessica
from
Brown,
what
by
I've
the
been
way.
told,
Yeah, great.
yes, Jessica Brown, when she came on to the team, they were named something else, and she said, I think we should rename our team. And she proposed the name, and everyone loved it, and so everyone voted on it. That's the
you need
story that's
T-shirts.
been told to me. Yeah.
That's what we said. That's what we said.
Yeah, for us especially. So, great name. Thank you. And, love that branding. Thank you.
Yeah, it's a double meaning,
It
what I mean?
does.
So,
Yes, it does. Yes.
Very strong meaning.
yeah,
So just one school, because we have workforce development in our Child Development Center,
yes.
is Immaculate Conception Academy out in the Mission.
That's my alma mater.
Oh, is it really? Okay.
I used to live across the street from that school.
That is my alma mater.
Okay, they're workforce interns we've had forever,
Yes.
and they're fabulous. But the best part in your pipeline, et cetera, is all of our front office, PSR's front office staff, they're all ICA graduates, and they did workforce development as high school students at our place.
Thank you.
So I'm just looking at workforce development programs in the city.
Yeah.
you might be able to push the envelope there then.
That's where I get the idea from. That's my alma mater, and
Okay.
it works amazingly well because,
Oh, yeah.
so the people, the students that go there, the organizations pay for their tuition.
Right,
Right,
yes.
at the school. And so it lessens the amount of tuition that they have to pay, but it's also giving them work experience. And it's opening up to different worlds that they otherwise would not have access to.
Commissioners, I'm sorry, we have to wrap up because the other meeting has to begin. I'm sorry, we only have like 6 minutes, and there's.
Okay, so
Thank you.
thank you, and
Thank you so much.
Katie.
Thank you, Katie. Thank you.
Thank you both, and that
Thank
you were
you.
able to, and it was nice to be able to discuss and have the time to discuss as we have to now wrap up. Okay,
And
thank you.
Commissioners, so if you have other questions or comments, please, you can forward them to me, and I'll forward them to
And
the
we'll
presenter.
answer. Thank you
Great,
all.
thank
all
you.
have a wonderful day.
Thank
Okay,
you.
thank you.
Item 5 is emerging issues. Any? Hearing none?
No.
Public comment, there's no public comment at this time, and so please consider a motion to adjourn.
So moved.
Second,
All those in favor?
Aye.
Aye.
Thank you.
okay.